Okay.
Добрый день, уважаемые друзья. Мы сегодня снова в эфире, и с вашего позволения я сначала представлю наших гостей, и если вы не против, я представлю их. Мы с нами сначала познакомимся на немецком языке, затем перейдем на английский, и я дам слово, затем передам слово Илье Черниковскому, который расскажет более подробно о нашем вебинаре. So, sehr geehrte Kollegen, ich möchte in den nächsten Minuten Ihnen unser Projekt vorstellen. Unser Projekt heißt For Surgeons Club und begann vor mehr als einem Jahr aufgrund der Corona-Pandemie. Und wir führen wöchentliche Webinare zur onkologischen Chirurgie, meistens auf Russisch durch. Ja? So, wir hatten auch mehrere Webinare in englischer Sprache mit berühmten Chirurgen wie Amjad Parvaiz und Professor Tobias Kek. Und ich sehe jetzt Grigori Lapshin auch aus Lübeck als Gäste. Und lassen Sie mich zuerst meine Kollegin und dann selbst vorstellen. As you see, here is Ilya Chernikovsky. He's head of Department of Colorectal from Moscow City Hospital, Oncological Hospital. Artyom Goncharov, he's head of Colorectal Department from President Hospital in Moscow. And as you see, Ilya Gotsadze, he's driving now in Georgia. He's working in University Hospital in Tbilisi. Und ich arbeite als Dozent an der Abteilung für allgemeine Chirurgie in Kiew an der Nationalen Medizinischen Universität. So, wenn Sie wohl fühlen, werden wir unser Webinar heute auf Englisch halten. Okay?
Yes, of course.
So, vielen Dank für Ihre Aufmerksamkeit. So, jetzt möchte ich Sie vorstellen, ja? Okay.
Yes, my name is Robert Gutzmann and I'm in Erlangen since 5 years when I took over from Werner Hohenberger. You probably know him. Every colorectal surgeon knows him. And my own specialty mainly is pancreas, but we try to continue here Erlangen's quality in colorectal. Today we will show you our open access and colon cancer, our improvement in surgery over the last years. So I can introduce to you, to start with, Professor Weber as our senior colorectal surgeon. He together also with Werner Hohenberger, and he is really one of the best German surgeons. And moreover, there is Christian Krautz. He came with me from a specialist for almost everything, especially minimal invasive surgery. So, but also they did it together, improved quite a lot minimal invasively. So we, in any case, do it same level of quality. What is most important for us, especially for the patients. So it's a big honor today to be here. The title is very encouraging. I hope you like it and that we will continue with this. Thank you.
Okay, thank you. And now I want to give a word to Ilya Chernikovsky from Moscow. He will speak in Russian and say a few words about today's webinar for our colleagues from Russia. Okay, thank you.
Дорогие друзья, всем привет! Я обращаюсь сейчас к нашей русскоязычной публике, тем, кто нас смотрит. Сегодня, как вы видите, у нас есть возможность пообщаться со знаменитой клиникой, с представителями знаменитой клиники в городе Erlangen. Мы все ее знаем, потому что колоректальная хирургия, хирургия колоректального рака сегодня без работы, которая вышла из стен этой клиники, невозможно. Я имею в виду Complete Mesocolic Excision, и сегодня мы будем об этом говорить. Знаменитый шеф в прошлом этого коллектива, профессор Хоенбергер, насколько я знаю, иногда до сих пор проводит консультации, но сейчас на пенсии. Я сейчас, как сказал Кирилл, хоть я вам сказал, что я from Moscow, но я сейчас нахожусь в городе Псков, один из старинных русских городов, поскольку ковидные времена закончились, и мы имеем возможность снова начинать нашу деятельность по проведению мастер-классов по колоректальной хирургии. И более того, что мне очень понравилось, сегодня я услышал такую вещь. Значит, в Пскове здесь наши коллеги смотрят наш Surgeons Club, и я могу с радостью сообщить сегодняшнюю такую новость для меня и для вас, я думаю, тоже. Хирургия, мини-инвазивная хирургия рака желудка была здесь, в этом учреждении, в Пскове запущена благодаря деятельности Surgeons Club, благодаря операциям, которые были продемонстрированы у нас здесь Ромой Израиловым и Алексеем Михайловичем Корочуновым. Это прямо мне сегодня было сказано, что благодаря этим выпускам они начали эту хирургию пока довольно успешно. Ну и чтобы мои слова не показались вам, так сказать, просто пылью, значит, я попрошу Мишу сейчас включить коротенькое видео из сегодняшнего онкодиспансера, из места, где я сегодня оперировал, и мы начнем наш вебинар. Всем привет! Чус! Добрый день, друзья! Сегодня у нас четверг, еще пока не 17:30, поэтому Full Surgeons Club еще не начался. Мы сегодня в Пскове, не мы, точнее я сегодня в Пскове. Это наши коллеги из знаменитого Псковского онкологического диспансера. Мы сегодня тут немножко оперируем кишку, как раз, так сказать, в тему сегодняшнего вебинара, где у нас будут гости из Erlangena. А пока мы передаем всем нашим сегодняшним слушателям привет от всех наших коллег из славного города Пскова. До встречи!
Кирилл, звук. Kirill, we don't hear you.
Thank you, Riyad. So, as you see, here was the colleagues from city Pskov. This is known oncological hospital where Ilya today performed two colorectal procedures. And I will give a word for your team, Professor Guzman, who will present.
Dr. Weber will start the presentation and his words, and your questions are always welcome.
Okay, thank you. Thank you.
We just published this. This book. It's about colorectal surgery. It's with the history also of the surgery of the colon for Hohenberger, and I hope that one time get it in Russian too. So, Dr.
Thank you.
Please.
Thank you.
Book about book.
Book about open.
Yeah.
So, hello again. And I want to talk today about CME, the CME paper from 12 years ago. And we can start with a PowerPoint presentation. The theme is Complete Mesocolic Excision in Colon Cancer, Principle and Background. Please. Next, please. No financial disclosure. Next, please. So, published the question, why should we perform CME in colon cancer surgery? Next, please. answer is to improve long-time outcome. Next, please. Of survival rates of rectal cancer in Germany over the years, especially in stage 3 on the right side, from the 70s, and on the right side, a large multi-center study, and the improvement in rectal cancer was 20% over the 30 years, and especially it was because the TME technique was introduced in Germany in 1990. It was first in 1982 by Bill Hilt and became surgery in Germany too. So next, please. When you look at the large study with 50,000 patients at the beginning of the millennium, you see that cancer had no difference in survival rates. This is astonishing when you compare the small abdomen, isn't it? So next slide, please. Rates of colon cancer in Germany over the last decades, you see that nothing changed for decades. The SKK study was a multi-center study of Germany, and the large carcinoma study. No difference in stage 1, 2, and 3. Over years, nothing happened. So, what means CME? CME is a specimen-oriented. The preparation is performed in embryological planes. The mesocolic fascia can preserve this way. Dissection of the supplying arteries, and you receive a maximum lymph node harvest. And the aim is to avoid any tumor spread and to obtain a complete mesocolic compartment with intact fascial layers containing potential deposits. Extracolic lymph node stations are considered depending on the two. So the next, please. So we start with a preparation which is embryologic, and thus the visceral plane is separated from the parietal plane. So the next, please. The technique of TME is focused on the sharp dissection of the planes. The plane, as Bill Hilt called it, the mesorectal plane, and thus obtaining. Next, please. Next, please. However, the anatomical planes are not limited to the mesorectal planes. Because of the embryological development, layers can be found in the whole gastrointestinal tract. As you see, the mesorectum is only a part of the dorsal mesenteric. So next, please. Next, please. As you see here, this is a photo from Professor. This is the mobilization in right hemicolectomy of the right colon from laterally to medially, as we do it in open. With the separation of the visceral and the parietal plane. Next, please. The next step in open surgery is that the duodenum and the pancreatic head are divided from the colon, and you find those embryological layers not only around the mesocolon but also Pancreas. So next, please. So the mesocolic people preserved by this operation. So next, please. As this is a photo from Thilo Wedel from Kiel. A CME specimen features an intact drainage with no tears in the fascial layers on both sides of the mesocolon. Note tumor deposits, or you find in lymphatic vessels tumor deposits. All is kept intact. No dissemination occurs during the preparation. So the next, please. So, like CME quality for rectal cancer, specimen quality for colon cancer, depending on the plane of surgery, classified into good. This is mesocolic plane, in moderate, intramesocolic plane, and poor. This Phil Quirk from Leeds described it for the rectum first and then for the colon, and he in the oncological features of the patient. So next, please. The Phil Quirk from Leeds, they made a paper about colon cancer. See, in the right colon, in the transverse and in the flexures, patients had poor specimen quality. In the left colon, it was better. You see, it's really disadvantage for the patients, as you see in the next slide. When you see the curative stage 3 and all stage 3, it's more pronounced. So the difference is quite amazing when you have good operation or even compared to muscular plane, where the outcome for the patient is very poor. The next, please. These are data from the classic trial, which are not published this way, but they are courtesy of who gave it. And you see that the local recurrence rates, if we have poor surgery quality, more than 20% in colon cancer, more than 20%. And when you have good specimen, you have local risk in colon cancer too, as you have it in rectal cancer. The next, please. So when you look at the disease-free survival, you see the good outcome for the poor specimen quality. And the next, please. It's more pronounced in stage 3. You have only 30% survival when you have bad quality of the specimen. So the next, please. So we did from Tokyo, and using an operative strategy based on the principles, you can over 90% of the cases a good specimen quality achieve. They had also no muscularis problem plane surgery, and we had also in the study no muscular all colon cancer from the right transverse and the left colon. So the next, please. See here specimen from our department. You can achieve a good quality of specimen in hemicolectomy, right? And in laparoscopic surgery too, as you see. The next, please. So, the anatomical structure untouched, as you see on the next slide. You see here the sympathetic nerves are left untouched, and we do not take by locally advanced tumors. We make a preparation which leaves this plane and we take every structure which is close to the tumor. Surgery. So the next, please. So the next step, form a central of the supplying arteries. The next, please. So, as you see here, the lymphatic drainage along supplying arteries in the Mesocolon on the location of the primary tumor. So, not one size fits all. You have to decide on tumor which artery have separated. For the right colon, these are the arteries along the mesenteric artery. For the left colon, is the arteries on the inferior mesenteric, respective the aorta. But the lymphatic drainage are the carcinoma at the spleen and on the hepatic flexures, because you have artery to supplying arteries, as you see in the next slides. The next 40 years ago, it was a Japanese pathologist demonstrated that metastases are first in the epicolic and paracolic lymph nodes, but not more than sides of the primary tumor, as you see here in the slide. The metastatic spread in artery towards the center, to the intermediate nodes, to the and finally or principal nodes, origin of the feeding arteries. So the next, please. So, the anatomy of the colon is very variable, and you have to think about that, and you have, because in every operation you find different anatomical variations which have to be divided. So in anatomical textbook, find, as you see here, an Iliocolic artery, a right colic artery, This is not the right colic artery we will only find in about % patient. So the next slide, please. So in this textbook, surgical textbook, you see it better. So here, Iliocolic artery, and you have here on the right side with no. But what is always wrong, or most, the right artery, when you have it in the textbook, arises from the superior mesenteric vein, but it arises from the gastrocolic trunk. Next slide, please. Vascular anatomy also for veins is very.
Уважаемые коллеги, у нас сейчас небольшая пауза. Как вы видите, есть задержка звука из Erlangena, поэтому попробуем наших коллег из университетской клиники переподключить сейчас. И если у вас есть вопросы, которые возникли на данный момент по поводу презентации, которую представил доктор Вебер, или, возможно, Илья или Артем хотели бы что-то прокомментировать, буду рад услышать. Спасибо.
Да, ну, во-первых, я хочу сказать, что это тот самый знаменитый доктор Вебер, который был одним из авторов той самой статьи 2008 года про концепт к мезоколической эксцизии, полной мезоколической эксцизии. Поэтому, ну, по сути, мы сейчас слышим этот концепт из первых уст, что называется. Вот, это первое, что я хотел сказать. Второе, у нас есть вопросы из чата. Мы их сейчас зададим, когда наши коллеги из Германии подключатся вновь. Вот. И, Тём, может быть, ты что-то хочешь сказать, потому что я боюсь, что у тебя назревает какой-то неприятный инцидент в твоей клинике. Скажи, что
четверг вечер, ты почему-то подозрительно долго с нами сегодня.
Это в любой момент может прекратиться. Меня заинтересовал слайд один из последних, где указано отступление от опухоли по стенке кишки. И там было интересно, мы обычно обсуждаем концепцию 5-10 сантиметров, а там было 5 и 7,5 сантиметров. Вот на последней вот Олимпиаде студенческой, в которой мы с Ильей Леонидовичем участвовали, мы столкнулись прям с неразрешимой такой проблемой, потому что совершенно разные есть подходы, сколько нужно отступать от, и нет единого стандарта. Вот мне хотелось задать вопрос, может быть, в чат, какой вы считаете правильным подход к резекции именно стенки ободочной кишки относительно опухоли? 5 сантиметров, 10, 7,5?
Да, потому что, честно говоря, во время этой Олимпиады возник спор, и та участница Олимпиады, которая отстаивала свою позицию, а ее позиция заключалась в том, что достаточно отступить 5 сантиметров вверх и вниз. И как мы видим на одном из слайдов сегодняшних, этот отступ для левосторонних раков считается адекватным, вот то, что мы сейчас видели. И, в общем, было много противоречивых мнений на эту тему, но она довольно стойко стояла на своей позиции, эта участница. И, в общем, я считаю, что она молодец, потому что много было серьезных хирургов вокруг, и она довольно уверенно свою точку зрения отстаивала. И вот, на мой взгляд, я тут соглашусь, наверное, с тем слайдом, что отступ 5 сантиметров вверх и вниз при правильной мезоколоктомии и центральном ликировании сосуда, мне кажется, вполне адекватен. И это, в общем, было доказано японскими коллегами. Что касается правой половины, там было указано 7,5 в проксимальном направлении и 5 в дистальном. Да, это интересное замечание. Пожалуйста, коллеги, кто смотрит нас, пишите. Вот тут пишут нам в чате, сейчас 5 сантиметров написали. Вот. Мы ждем ваших мнений тоже по этому поводу. Вот. Сейчас, я так понял, Кирилл, к нам подключаются, да, снова наши друзья.
Да, они пробуют как раз подключиться. Но я думаю, что эта проблема связана с тем, что есть firewall во всех клиниках Германии. Поэтому, скажем так, и интернет не вчера проведен в Erlangen, как вы знаете, или, возможно, не знаете, Erlangen, если я не ошибаюсь, это самый старый медицинский университет Германии, медицинский факультет, точнее. И so, colleagues, are you hear us?
Вот нам отвечает наш большой друг из Германии Леша Сахаров. Он сейчас в Германии, как раз таки в Баварии. Он отвечает 5 сантиметров.
5. Colleagues, are you hear us? Dr. Weber?
Нас слышат?
Вас слышим, вы нас?
Отлично. Мы можем продолжать.
Мы прекрасно вас слышим. Супер,
Качество
отлично.
стало?
Продолжайте презентацию. Намного лучше.
Вот тогда. Ist viel besser geworden.
Kann ich so von dem Tier aus weitermachen oder von was anderes? Soll ich nochmal zurück oder?
Вернуться немного назад или продолжить с этого слайда?
Можно на
Ja,
один
ich denke
слайд назад.
noch einmal zurück. Ja. Wo Sie haben diese 5 und 7 und 5 Zentimeter, okay? Михаил, можете отлистать назад на несколько слайдов? Там еще я скажу вам, когда.
Вот все.
Да, вот здесь, наверное, да.
From this slide.
From the slide.
From the slide, please.
You hear me?
Yeah,
It's
thank
better
you.
now?
Yeah, of course. Thank you.
Okay. So, CME surgery, central dissection of the relevant tumor feeding arteries right at their origin is performed. And towards the right-hand side of the patient, you separate the arteries which had their origins on the superior mesenteric artery. And for tumors on the left-hand side, you separate the arteries at the inferior mesenteric artery, respective at the aorta. And the complex tumors are the tumors of the flexures and of the transverse colon because they have two lymphatic drainage on arteries. The splenic flexure drains to the middle colic artery and the left colic artery, and the hepatic flexure drains to the iliocolic artery and to the middle colic artery. As I told you before, the right colic artery is only found in 20% of patients. So the next slide, please. So 40 years ago, the Japanese pathologist Chinai demonstrated that the potential metastases in lymph nodes are firstly located in the epicolic and paracolic lymph nodes, but no more than 10 centimeters away from both sides of the primary tumor, as you see here in the slide. The metastatic spread then follows the supplying arteries towards the center, to the intermediate nodes, and finally to the main or principal nodes at the origin of the feeding arteries. So the next, please. So in the operation of colon carcinoma, you have always be aware that anatomy is different in every patient. That means in every patient you have to look which arteries are feeding the tumor and which arteries has the patient, because it's really different. If you look at textbooks of anatomy, like here in the slide, you always find an iliocolic artery, a right colic artery, a middle colic artery on the right side. But this is not true, because the right colic artery, as I told you, is only here in 20% of the patients. So the next. In this textbook, the surgery textbook from the USA from 1961, you see it better. You have here on the right side a iliocolic artery, which divides in the iliocolic branch and in the right colic branch and the middle colic artery. But what you always find here in the textbook is that you always have on the right side right colic vein, which derives from the superior mesenteric vein. But this is not true. Please, next slide. In most cases, the veins on the right side, they come from a gastrocolic trunk. We call it the Henle trunk. And you have always, the anatomy is very variable in every patient. This is not for oncological reason, because the lymph nodes are along the arteries, but it's because of preparation reason. In open surgery, it's not as relevant as in laparoscopic surgery. You have to avoid tears in the arteries on the pancreatic head. You find this gastrocolic trunk on the pancreatic head, because when you have tears in the vein, you have bleedings, and it's very bad for the patients and for the outcome of the patient. So the next, please. So what we do for different locations, we do different operations. These are the standard operations for colon surgery. A right hemicolectomy, as we call it. We separate the iliocolic. You will see here a right colic, which is not always here, and the right branch of the middle colic artery. That's the standard anatomy as here, but without the right colic. The easiest operation is the sigmoid resection. We divide always the inferior mesenteric artery at its origins, and we separate then the left colic artery in this high as you see it, and we separate the rectum in the upper third. And for tumors of the descending colon, you perform a left hemicolectomy. We divide the inferior mesenteric artery at its origin, and we divide the colon close to the splenic flexure, and the left colic artery with potential lymph node metastasis is fully included in the specimen this way. So the next, please. So in open surgery, you can do diaphanoscopy, as if in these pictures from Professor Hohenberger. You see the middle colic artery. This the standard sedation. I told you the middle colic artery has a main branch which goes to the left hand of the operator, and you have the right branch, and you divide the right branch of the middle colic artery right at its origin on the main branch of the middle colic artery. And you see to the right hand of the operator is the Iliocolic artery, and you divide it at its origin at the superior mesenteric artery. So the next, please. So here, this is separation of the Iliocolic artery. In about 1/3 of the patients, the Iliocolic artery comes from below the superior mesenteric vein in our patients, and in about in 2/3 it comes from below. In 1/3, this artery comes from above, from the left side of the superior mesenteric vein. And it's separated, as you see it, at its origin. The next, please. So, in addition, extramesocolic lymph node stations are considered depending on the tumor site. The next, please. What are extramesocolic lymph node stations? As you see here, you have a tumor of the hepatic flexure, and in tumors of the hepatic flexure, you have potential tumor metastasis to the gastroepiploic lymph nodes and the lymph nodes at the greater curvature of the stomach. In tumors of the transverse colon, you have potential lymph nodes at the gastroepiploic arcade at the greater curvature of the stomach. The same in tumors of the splenic flexure. In addition, tumors of the transverse colon and of the splenic flexure might have lymph node metastasis at the inferior aspect of the pancreas. So the next slide, please. So this is the location of the potential apparent lymph node metastasis dependent on the location of the primary tumor. As I told you, the right third of transverse colon and hepatic flexure might have infrapyloric lymph nodes or even lymph node at the pancreatic head. Tumors of the middle third of the transverse colon might have lymph nodes at the gastroepiploic arcade at the greater curvature, and in addition at the inferior aspect of the pancreas. The same is for the tumors of the left third of the transverse colon and the splenic flexure. Please, the next one. So, in 1941, this was described for the first time from Corporal, an American surgeon, who finds nodes along the greater curvature of the stomachs in carcinoma of the transverse colon. And he even find in advanced cases lymph nodes to the spleen. So the next one, please. So we did a study in almost 10 years ago, and with carcinoma of the flexures and of the transverse colon, and we find involved gastroepiploic lymph nodes in 12% of patients who had lymph nodes in the mesocolon. And we find lymph nodes and the infrapancreatic lymph node region in 20%, also in patients which had lymph nodes in the mesocolon. We didn't find lymph node metastasis at this apparent stations in patients who had no lymph node metastasis in mesocolic lymph nodes. Bertelsen from Hillerød, he was in our department for several times, and he introduced the CME concept in Denmark, and he makes a lot of studies on this topic, also with laparoscopic surgery. He performed this study too, and he also find this lymph node metastasis in 12% of patients who had involved lymph nodes in the mesocolon. In 4%, he find metastasis of all included patients. This means negative and positive node patients in the mesocolon. So the next, please. Already in 1995, this was described by Toyota, the Japanese surgeon for tumors of the right flexure, of the hepatic flexure. And he also finds in 4% lymph nodes in the infrapyloric region for all patients he had in his study. This means node positive and node negative patients for the mesocolic lymph nodes. And when you look at the picture on the right side below, you see one patient had a lymph node in the infrapyloric lymph region, but he has no positive mesocolic lymph node. So this is a phenomenon we didn't notice in our patients in our study. So the next, please. So I want to show you now a film I performed 5 years ago, almost. It will be an extended right hemicolectomy in carcinoma of the right transverse colon. Can we start the film? So you have a huge tumor at the right transverse colon, and we start with a lymph node dissection along the greater curvature of the stomach. Here we take the ligature and we separate here the gastroepiploic arcade. Then we dissect the omentum. The omentum on the left side can be preserved. Only the omentum on the right side would be en bloc with the tumor. Now we make a complete mobilization of the right-sided colon and mesocolon in open surgery, always from laterally to medially. So the next step is the mobilization of the hepatic flexure from the pancreatic head. So complete mobilization of the right hemicolon. And then this is the Iliocolic vein. In this patient, the Iliocolic vein comes from the gastrocolic trunk of Henle, which is very uncommon. The dissection of the infrapyloric lymph nodes is continued from left to the right side. And now we perform the lymph node dissection at the pancreatic head with division of the right gastroepiploic vessels. First, we divide the vein, and then the artery. So this is the tumor en bloc separated from the greater curvature and the duodenum. Separation of the omentum from the left-sided transverse colon. This is the middle colic artery, which is a lymphatic drainage of the tumor and has to be separated later. So first, the next step is here, as I told you, the separation of the Iliocolic vein, which arises here from the gastrocolic trunk of Henle. This patient had no other vein to the right hemicolon. Now the mesentery of the terminal ileum is divided. So the next step is division of the middle colic vein. So middle colic vein here, superior mesenteric vein, Iliocolic vein, already separated here, the gastrocolic trunk of Henle, as you see it here. The next step is the dissection and division of the Iliocolic artery, which is the second lymphatic drainage of the tumor of the right transverse colon. So Iliocolic artery comes from below the superior mesenteric vein in this case. So here you see the artery from below the superior mesenteric vein. Now exposition of the middle colic artery from the right side on first. So, and then mobilization of the mesocolon from the inferior aspect of the pancreas. So when you separate the mesocolon from the inferior aspect, you find 3 to 4 small arteries. And in these arteries, you find these aberrant lymph nodes on the inferior aspect of the pancreas. This is in this tumor, you have not to separate these arteries, but it's only for demonstration. And we go on with our tumor. Now we have a caudally exposition of the middle colic artery. So a small left branch of the middle colic artery to the splenic flexure can be preserved, as you see it here, because it has nothing to do with the tumor drainage and with lymph nodes. So it follows the circular dissection and division of the middle colic artery. This is the middle colic artery. So is fully dissected and can be divided now. So middle colic artery, Iliocolic artery, middle colic artery, Iliocolic artery, Iliocolic vein in this part, middle colic vein. And the next step is the separation of the left-sided transverse mesocolon. And here the preservation again of the small branch. And here the superior mesenteric vein. With the separated vessels at the origin. So we can go on with the slides. So this is a specimen of the patient from the backside. He had no lymph node metastasis, but 42 lymph nodes were examined. We did no adjuvant treatment with him. So the next slide, please. So I show you pictures of the left transverse colon, is a huge tumor of the left transverse colon, and we do en bloc resection with the omentum. The next slide, please. As you see on the right side, the omentum was removed. The inferior aspect of the pancreas was dissected. The next slide, please. So again, the exposition with the dissection of the lymph nodes along the greater curvature of the stomach, the dissection of the lymph nodes at the inferior aspect of pancreas, and the central dissection of the vessels. So the next, please. And the last picture of the patients, and you see the clips and the inferior aspect of the pancreas, and the clips. These are the small vessels I told you on which this lymph node, this potential lymph node metastasis are located if the patient would have metastasis. So the next, please. So what are our data in stage 3? Local recurrence rates for the years in Erlangen could be reduced to 4%. As I told you, also in colon cancer, in advanced colon cancer, you can have local recurrences. It's not zero. Nobody talks about local recurrence in colon cancer, but you find it and we find it. So the next, please. When we look for overall survival, also overall survival in our department for stage 3 is now at 70%. That means it's 20% above the level of Germany. And the next, please. The same is for cancer-related survival. The cancer-related survival in our department for stage 3, 5 years is over 80%. So the next, please. So again, what is complete mesocolic excision? An anatomical preparation in embryological preformed planes. Different tumor locations require individual operative strategies. The extent of lymph node dissection and mesocolic resection for each tumor depends on the location of potential tumor deposits in lymph nodes along supplying arteries and aberrant lymph node stations. So the next, please. So this textbook from 1961 shows no CME. You have blunt dissection, you have small segment resection of colon, but it was standard in this time in the US. So the next. Over 100 years ago, 1909, in Leeds, Jameson and Dobson described a correct dissection of colon carcinoma. You will see here, the right side is for right hemicolectomy, and on the left side and the right side is for an extended right hemicolectomy. And they already knew which lymph node stations were involved and which lymph node stations had to be separated, and as you see it, with central vascular ligasion. So thank you very much.
Thank you so much.
Thank you, Dr. Weber.
Thank you. And I have to say that the sponsor of our webinar today is Herb Company. Many thanks for Herb Company. And we have some questions. The first one, we have two questions. I'm sorry, two questions from a country somewhere between Russia and Germany. Can you hear me?
With internet connection.
Can you hear me? No.
I can hear you. Yes, I'm here on a laptop and I try to hear you.
Okay. We have two questions from a country somewhere between Russia and Germany. I am talking about our beautiful Belarus. You know this country, Belarus? Okay.
No. Only from the lens, from the car, from Atlas.
The first one, should right gastroepiploic vein be preserved or dissected at its confluence with gastrocolic trunk and in patients with hepatic flexure or transverse colon cancer? Your opinion, please.
We always separate in patients with hepatic flexure cancer and cancer of the right transverse colon. We always separate the gastroepiploic vein at its origin at the gastrocolic trunk of Henle.
Thank you. And second question from Anton Tur. On your opinion, is injury of thin part of mesocolon window through which duodenum is seen during right colectomy a disturbance of CME principles?
The window in right hemicolectomy should be preserved. It's very thin, and but sometimes it tears by preparation. I personally, when the tear is small and the tear does not go on in the mesocolon, when it's only in the window, I don't know whether there are relevant lymph nodes in this area. I don't know. Yeah, also I would think it's not. You should not do it because you have a nice specimen when everything is preserved. But I personally think when it's a small rupture, it will not disturb the oncologic outcome. That's my personally, but I cannot provide data on it. Because the lymph node metastasis is along the arteries, and when you have the arteries preserved, the tissue around the artery, I don't think that the tissue in this window contains very much lymphatics which are involved. That's my opinion.
Thank you, thank you. And one question from me. We know that there are no randomized controlled trials showing the superiority of CME. Okay. We also know that tumor biology is much more significant predictor of prognosis. For example, for a patient with a tumor, right side tumor with BRAF mutation, to perform CME or not to perform CME, it's not difference. But we routinely perform CME. Why? Because it's less blood loss, because white surgery, because it's beautiful. But we now we have no randomized control trials. Okay, what do you think about it?
You have no randomized control trials, but also for TME, you had no randomized control trials. When Bill Hilt introduced TME, then TME was standard and no trials were done with the old operation technique. You must remember that. And
yes.
I think we make standard operation for every patient because we don't know whether the patient has lymph node metastasis or not. And therefore, it's better to do the same for every patient and also to compare the quality. When you say in one patient I do not, and in other patient I do, so there you randomize in front, and you afterwards, when you want to have your results, you cannot compare it. So I think you should do, and we do it, we should do always the same principle as we do always the dissection of the greater curvature. Today, I assisted a tumor of the transverse colon, it was small, and the assistant asked, is a small tumor, should we do dissection of the greater curvature? So I said yes, because you cannot say in front whether the patient is nodal positive or nodal negative. Even you have a small tumor, you can have small tumors which are very aggressive. So I think you should do always a standard operation in colon cancer for each patient and for each location, and you should not decide in front. You make it. You make a CME in this patient, and in this other patient you make no CME. That's my opinion.
Thank you. Thank you.
You're
Guys?
welcome.
So, thank you, Dr. Weber, for excellent presentation. I think most of surgeons have only read your publications, and today, thanks to new technology, and despite the COVID pandemic, everyone has the opportunity to see how to perform complete mesocolic excision. Yeah, and I have two questions for you personally. What is your opinion with the introduction of laparoscopic surgery? How has approach to open colon surgery changed?
So I learned the colon surgery from Professor Hohenberger. He was my teacher for a long time. And Professor Grusman is now the head of department since 2015, and he introduced colon cancer surgery. Also laparoscopically we started, and I also take part in laparoscopic operations. I do not do that for my own, but I like to assist them. And I give advice because I have the experience from open surgery, and it's good to have somebody on the table who has anatomical views and everything. And it's no problem. We do operations open, and we do laparoscopically. Advanced cancers, large cancers, we do for open surgery. Cancers at the flexures and the transverse colon, we do for open surgery. The other location, we make laparoscopic surgery. In obese patients, sometimes we have to convert, or we decide from in front. But in our department, it's side by side opened and laparoscopic surgery. And we have enough patients to do that. And I think it's benefit for everybody that we can do both techniques with this patient.
Thank you again, Dr. Weber, for excellent presentation and for sharing your great experience today with us. Ilya?
We have one question from Evgeny Frank about why your choice is lateral approach. What's the benefit?
Why the medial lateral to medial approach, or?
Yeah, why?
Because this is the traditional approach in this department for 50 years. Since the Second World War, the lateral to medial approach was performed, and I didn't see it I didn't see it from medial to lateral. In laparoscopic surgery, we do it now from medial to lateral, but for open surgery, we didn't change the technique, and it was like 50 years ago. So I see no disadvantage for lateral to medial in open surgery. For laparoscopic surgery, I think medial to lateral is better. But for open surgery, I see no disadvantage. And as I showed you in one slide, when you made a complete mobilization from lateral to medial, you can make diaphanoscopy. Then you see the vessels, and then you separate the vessels. There are hospitals in Germany which separate first the vessels and go then from medial to lateral. But we see no oncological disadvantage. We compare our data with other hospitals. We make internal quality control, and nothing has to be changed it has not been changed. And I don't think that medial to lateral is better than the other way. So.
Okay, thank you.
Thank you very much.
Okay,
Goodbye.
thank you, Dr. Weber. We move on. Bye. And I want to give a word Christian Krautz. He will present today laparoscopic approach for right hemicolectomy. Christian.
So, hello and welcome from my side.
Hi.
Hi.
So I'm really glad to have the chance to talk to you on this occasion and media. So to continue the topic of CME, I would like to show you our standard approach to laparoscopic CME. And yet, next slide, please. So you heard about the data already from our clinic. So we can skip this. Can you tap once for the next slide, please? There's new data too, and there was the question why there isn't any RCTs, or we don't have data for RCTs. The thing is, the data that supports CME is just as strong that actually no ethic commission would really allow a RCT. And I don't know if anybody would, with a look at the data, also this study, this population-based study here on the right side from Denmark, would like to have an operation with a non-CME. So I think there will never be data from an RCT on this subject, and but that's okay, because population-based data show that CME has much better survival than non-CME approach. Okay, next slide, please. And in Germany, our guidelines, I have to excuse the slide is partly in German, say that the CME should be performed. And if you can do it laparoscopically. And it's not a strong recommendation, because we know the CME openly is already pretty intense surgery, not easy to perform, and laparoscopically or minimal invasively, it's even more challenging. So it shouldn't be taken so easily. But there's data, you see it on the right side, that at least the laparoscopic approach isn't inferior to the open approach. So if you can, you should perform it. Okay, next slide. But the thing is, what is so special about CME, and especially the laparoscopic CME? And now you can see a 3D reconstruction of the mesenteric axis of the vessels, and you heard all about the anatomic aspect from Dr. Weber. And the thing is, the anatomy is just really complex. So we need to have a standard. We need to standardize the approach, and we need to have good teaching tools to really have everybody perform a safe CME with a minimal invasive technique. Please, next slide. Once again, and once again. So the thing is, standardization is something which is really critical. And in Germany, a bunch of experts developed a standardized approach with several critical views, just like you have it in gallbladder operations, to standardize the right hemicolectomy with CME and to make it safer. And now the following video, I will show you this approach and also the steps and the critical views that we think are important to have a safe operation. Next slide, please. And once again, we call this standardization, or let's say the standardization is based on an open book model. So you have 3 planes, as you can see it here on the left side. There's the lower plane, that's the plane of the SMA or of the mesenteric axis. Then there's the middle plane, this is the transverse colon plane, and then there's the upper plane, that's the gastroepiploic or gastric plane. And these planes are important for our steps. Next slide, please. And we have altogether 8 steps and 8 critical views where you have different looks from different sides of these planes. Okay, let's have a look on the video. So we need to switch. Okay, this is our setup for the OR. The surgeon is on the left side of the patient. The assistant is in the middle, so it's a French position. We use 4 trocars, 2 bigger ones, 12 millimeter for the cameras, so we can switch the camera from the umbilicus to super. Can you stop it, please, for a second? Yeah. So we can, or can you turn it back a little bit? Is it okay? Yes. So we can switch the camera between the umbilical port and suprasympathetic port that changes the views and enables us to have a different look from different sides. I will show it to you later. And the working parts are on the left side, in the middle, and on in the lower part of the left belly. Okay, yeah, now continue. So first, we start with a adhesiolysis, if there are any adhesions. This is a case of a almost 80 years old female with a cancer in the ascendant colon, and she was really suited for a video because she was really thin, so we could really have a nice operation with didactic views. We start in a we start to, can you stop it, please? We start to sorry, to put all the small intestine to the right upper quadrant. The patient head is bottom up, so everything falls cranially, and we start with our medial to lateral approach, if possible, at the emptiness of the pancreas. So this is now a view. This is the beginning of the jejunum, and here we start to go from left to the right on the pancreatic head. Okay, please move on. This is a Uncinet's first approach that was published by Stefan Benz, also famous German colorectal surgeon. And you see now here that we already mobilized the mesocolon from dorsally, from the duodenum, and now we go ahead to mobilize it from the pancreatic head. And then we move on to go laterally. Of course, you can also start up from the lower abdomen and go up, but actually, if you really mobilize it this way, first you usually go a little bit up further, which helps later on, because the concept is that this is the first critical view, actually, the mobilized mesocolon from the pancreatic head. So now we put swap in there, so we can have a nice orientation. And now we put the small, can you stop please and go a little bit backwards? Sorry, I'm not as fast as the video in English. So now we put the small intestine to the left side, and we have a look on the mesocolon ascendens from ventrally, and this will be the second critical view, which is called the V look or V view. The purpose of this view is to identify the Iliocolic vessels and the mesenteric axis. And because we did the mobilization dorsally first, it's much easier to identify the vessels, even in more obese patients, because usually the window between the Iliocolic vessels and the mesenteric axis will be much better seen if you mobilize it from below. And moreover, it's much more safer to dissect this window when it's not sticking to the retroperitoneum where the ureter is located. Okay, let's go on. So this is the critical view. And here you have a 3D reconstruction we use to have a look at the vessels. Mostly in minimal invasive surgery, it's not bad to have such reconstructions, so you have a good knowledge of the anatomy. So now I'm dissecting or making a window in the window of the mesoileum, so between the Iliocolic vessels and the mesenteric axis. I divide the meso, and because we mobilized it from dorsally, now again, 3D reconstruction once again. Okay, let's stop the video for a moment. Yeah, because we mobilized the meso from dorsally, we now are able to look from above, from ventrally, and also from dorsally, and it's much more safer and much easier to identify the vessels. Okay, go on. So what you can do is do the dissection from ventrally, and then you can also lift up the tissue like this, and then you can do the dissection from dorsally. And you already know where the pancreatic head is because you mobilized it already. And please stop here. And now it's important to stay on the left side. Go with the direction to the left side and be cautious for the mesenteric axis. So there will be the SMV and the SMA. Usually, when you are below the Iliocolic vessels, as we are here, the SMA is still on the left side, will come first, and then the SMV depends on the height where you are. Okay, let's continue. In this patient, because here it was a tumor of the distal ascendens, please stop here. I stayed relatively close to the Iliocolic axis. Usually, I also put the dissection even a little bit more to the mesenteric axis. And now you see at 6 o'clock already the SMV, and at almost 9 o'clock there's the Iliocolic vein insertion to the SMV. Okay, let's move on. And when you identify the SMV, go on the ventral side. This is a really good plane to go on with the dissection. Once you identify the SMV, you are really safe. Just go on ventrally first, and then when you see where it is, you can go on the right side and even on the dorsal side. And this is again here the point to mobilize the mesocolon first to be able to perform this dissection from dorsally too. So this is the next critical view, the safe, okay, stop it here, the safe identification of the insertion of the Iliocolic vein into the SMV, and for that the SMV has to be shown cranially and also caudally. So you really know that's that you are on the right place. Please go on. We usually use clips that are applied when you are mobilized the vein at the insertion enough. For the vein, I only use one clip. At each side. So, okay. So at this point, of course, it's necessary to know where the Iliocolic artery is coming from. Most of them are coming dorsally from the SMV. So you heard it already, in 80% almost. In this patient, this was the case. When it comes dorsally, it's usually a little bit higher up than when it comes from the ventral side of the SMV. And now it's safe to continue the dissection on the SMV first, on the ventral side. And I like to use the ultracision device, the harmonic, because it's really nice to dissect the tissue from vessels. So, and you can take small bites and precise bites.
Especially this new one model, yeah?
This is a new model, yes. It's thinner, so you can even be more precise. So I really like it. So then when you did the dissection on the ventral side, you go to the right side, and then again from dorsally. And here you have to be cautious, because when you already cut the vein, you pull the SMA to the right side, and you really have to be cautious not to go too close to the artery or even hit it. So stop it here, please. When you see it now you can see it quite good. The SMA is makes a little curve now because I pull it to the right side. So you really have to be cautious. Don't go straight. You have to go a little bit to the right side as the curve of the artery. Okay, let's go on. And this is the fourth view, the beginning of the Iliocolic artery. You have to really see that it is the artery at the right space, and you have to see the insertion point to the SMA. And then it's clipped and cut. For the artery, I use 2 clips centrally. We always, in our standardized approach, keep the nerve tissue on the SMA. Stop it here. And to prevent any diarrheas or to prevent accidental hurting of the SMA. And this is also the approach in our open way. But there's also, and I will show it to you later on with the robotic dissection, the really D3 dissection right on the artery, but this is not how we do it standardized. So now the next part is going up a little bit more, and now you have to be clear what the anatomy of the veins are at the truncus hende, and there's a scheme here, and I like pretty much, because actually there are 3 types of the truncus hende, and most type is that you have 3 veins going into the trunk of hende. Okay, let's go on. And now you can go a little bit further up on the vein, but you should stop at this point and do the next dissection step, which is to go into the bursa orbitalis. so that we keep on going with our open book model. So you see now here the pancreatic head. Stop it, please. The truncus händle, the pancreatic vein that go into the pancreatic head, and then the superior right colic vein that is draining into the trunk of händle. The gastroepiploic vein is now not visible yet. Therefore, we switch the camera up to the umbilical port and do the dissection in the bursa ommentalis on the omental sac. Okay, let's go on. There's also the middle colic vein. So now the camera went up from the supra pubic port to the umbilic port, and we go into the omental sac. And this is the step number 5, the opening of the omental sac. And now we mobilize our second plane of the open book model, the mesocolon the mesocolon and transversum plane. And then we go to the right side, right where the gallbladder is situated. Please stop. And divide the omentum. We always take a little bit of the right omentum, even though you don't need to do it. It's a much easier approach when you do it laparoscopically. So you go into the omental sac right beneath the gastroepiploic arcade, and then you turn to the right side and go to the gallbladder, and then you will come to this situation where you have the gastroepiploic vessels on the right side at 11 o'clock, and at the left side of this picture you have the superior right colic vein that is draining into the trunk of händle that we have already seen from the other side. So please continue. So again, this is our open book model. Now we have two sides where we can look from. One's from this side and one's from dorsally. And you keep on with the dissection in the direction of the gallbladder. Leave the gastroepiploic vessels on the right side, and then you already see our swab that we placed on the pancreatic head, and then you connect the level, or then you connect to the level that we mobilized before, okay? And here we had a small right superior colic vein that we just dissected with the ultracision, so no clips for that. And this is cut now. And then we established the connection to the pancreatic head. And from there you can go to the lateral part, but we now want to finish the central dissection. This is step number 7, where you identify the middle colic artery and veins. In this patient, there was a really long colon transversum, so she had long vessels that made a curve quarterly, and here we had to be cautious not to cut the left branch of the middle colic artery, which is here on the right side from the dissection device. And this now here will be the right branch of the colic artery, which is now already mobilized and then again clipped and cut. And then this patient, she didn't have a right colic vein, but she had a right branch of the middle colic vein, which was pretty strong. This one that is now clipped and divided, and the left colic vessels are kept intact here on the right side of the picture. And then you dissect the mesocolon of the transverse colon all the way to the intestine. And this is now the last step. Now we look again, camera comes from the pubic port, and now we look from underneath at the trunk of Henle. Stop it here, please. And you see that we did a really nice dissection centrally. Okay, let's go on. And all the veins are kept in place except the veins on the that had to be resected. So now the view from above. These are the middle colic vessels. Then comes the SMV. And you see there the clips of the colic vessels at 6 o'clock. Yeah, there. Yes. And the trunk of Henle and the pancreatic head. So nice CME. And now comes the lateral mobilization. And well, this is straightforward. Now the hard part is already done. Of course, you need to be careful to keep your plane and to keep your package so you have a nice CME all the way through. This is now the preparation from below. Yes, and this was our specimen, and the tumor is here at 12 o'clock located, and was 3.1 centimeters, and this is our port placement after the operation. The patient was went home at the 5th day, so everything went well. Okay, so to put it together, what's important for the minimal invasive right hemicolectomy with CME? In our view, it's all about standardization, and standardized steps with critical view can help to increase safety and can help to promote teaching. In our view, also CT reconstructions can help in preoperative planning, so you are aware of the difficult vessel anatomy, and during implantation, of course, you should take account the patient selections. Don't start with too obese patients and not with too big tumors, then you will be safe. Okay, so maybe we can have already some question if there are any other way we can also
thank you so much. It was very beautiful surgery. Maybe we have some questions. Ilya?
Thank you very much. Thank you very much. Very nice surgery, and it seems that your temperament allows you to operate so cleanly and dryly. So I would like to ask you some questions. So what is the duration of your right standardized colectomy? And do you have any time limits in your clinic? And the second question, you look very young and you are already operating very confidently, and we watched to the very nice surgery. Could you please briefly describe and tell us several words about your learning curve? Thank you.
So the usual time is 3 hours for the laparoscopic CME. And I think you can be much faster if you do it really carefully. Of course, in thinner patients, you are a little bit faster, but it's around 3 hours. I think that's a decent time. And when the patients are more weak,
time limit. Do you have any time limit in your surgery? So if you operate, sometimes you cannot finish your surgery in 3 hours, and your duration can be 4 or 5 hours. Do you have any? Do you have any time limits? Any problems when your duration is prolonged in time?
So no, not by time. So if I see, so there must be other factors. So if I see this isn't good, there are any problems that slow me down, then I have to think about converting. But it's not just the time. If it takes a little bit longer because the patient is obese, it's fine. But usually it's not more than 3 hours.
Thank you. And some words about your learning curve in open and laparoscopic surgery. Can you give some? Maybe you can give some advices to our young audience, because students, residents, and young surgeons are watching to you, and maybe you can share with them briefly with your experience in that concept.
So we are, or we have a skills lab where we do our laparoscopic training, which is really important. And also I look young. I'm not as young as you think, maybe. And I'm teaching younger colleagues, and my point that I want to make here is that the thing to have good teaching is the standardization. If you always do it the same, if you have your steps, then you can look how, and you have to adjust, and you have to know your younger colleague. And then you can say, okay, this step, this is okay, you can perform it, but then the next step, maybe dissection at the truncus hende, this is nothing for you at this moment. I will take over for this step, and then you can do the next step again. So this is the way we do it. we do it actually. There have to be younger colleagues have to be really advanced in laparoscopic surgery already before they can perform such a surgery, in my opinion. And I wouldn't let anybody that I don't know perform any steps. So usually we start with a sigma resection in our young colleagues, and then when they do it, when they can perform it well, then we switch to the first steps of the CME. But in our approach, the CME is not educational, or how to put it, it's not as it used to be an easy operation that can be teach to everyone.
If I can add something, so time is not our currency, so but quality. What us helped here is also the high quality before an open operation. So also Dr. Weber and Dr. Krautz operated quite a lot together. But I have to say, of course, Christian Kraut's learning curve is really steep. So with that operation, we really exactly in that technique, we started here 5 years ago, laparoscopically. So, but it's always the quality comes first and then time, because the outcomes is most important for the patient. And then, of course, teaching. So he is a really clever guy and trained a lot in Skills Lab. And yeah, that helps. And maybe it also helps the knowledge of anatomy and also good open operation. So if you know the anatomy from open operation very good, you can translate it much easier to laparoscopic surgery if you're just a beginner.
Thank you very much. Thank you.
Thank you, Professor Grutzmann. Thank you, Christian, for excellent presentation. As we see, this combining open book model technique, as I know, and show us really clear dissection and safety checkpoints, and it looks safe, yeah, and for teaching also. Maybe you know, but in eastern part of Europe, in countries such as Russia, Belarus, and Ukraine, we use another technique, which was introduced by Amjad Parvez several years ago. So we start from Iliocolic pedicle, and then we go to superior mesenteric vessel. But this technique are also very interesting. Thank you very much. It looks safe and beautiful. Thank you again. And we move on. Next presentation will be about robotic surgery. I give a word for Artem Goncharov. He will say something about this elektronische Geräte, die benutzt man mit robotischer Chirurgie. Okay? Danke.
Okay, thank you very much. We see a very nice laparoscopic dissection, and we think that we will see a very nice robotic. And I want to ask you, do you think that robotic have some advantages in the colon surgery? Because it's the question. Many surgeons say that the robotic is good for TME, but CME is better with laparoscopy. Thank you, and wait for your presentation.
So I think, and I hope I can show it with a video, that there are advantages. And because in this video I will perform a D3 dissection, so I will really go close to the artery and make it naked on the right side, which is really safely to perform with a robot. And what I think is a main advantage that maybe is not as good. I don't know if it has any relevance when you do the dissection on the vessels from dorsally. It's not easy to do it laparoscopically, or you cannot. Ventrally, you can go a little bit to the left side, but dorsally you cannot go to the left side as far when you do it laparoscopically. But in the robot, with the angulation, you can go really also dorsally to the left side. So you have a more radical lymphatic dissection. If this is if this has any clinical relevance, I don't know. And of course, the handling is, I think, safer, and the robot will enable more people to perform safe surgery, I think. So this is an advantage. Okay.
So let's go to presentation.
Let's
yeah,
go to
start.
your presentation, okay? Okay. Mikhail? Там по роботической хирургии, да.
I think we have to skip the first slides because they are pretty similar to the last presentation. Yes, go ahead. Yeah, next slide. We have to skip some slides. Again. Sorry, this is in German. Again. Okay. So this is our setup for the robotic operation. So we have an XI system, and we use the straight line suprapubic placed, and then the assistant trocar on the left side. And we do the specimen retrieval in the middle of the two trocars, so we connect them, and then you have a specimen retrieval incision in the middle. Okay, so let's go on. We start with the first step. It's the same as before. Okay, I think you have to hit it one more time. Again, I start here at the pancreatic head from the left side. And do the mobilization. And this is the first step. Okay. Then comes the next step.
Christian, can I ask you a question?
Yeah.
As we see, you use L-hook with monopolar cautery, yeah, here, and in laparoscopic surgery, ultrasonic devices.
Yeah. Well, in the robot, you can have the ultracision also as an instrument, but you cannot do the angulation. So I don't like it, and therefore I use the hook, which also enables really precise dissection of vessels. So when we also do gastric surgery or pancreatic surgery with the robot, and there we also use the hook for vessel dissection. So this is pretty nice instrument, I think. you can use it in combination with another sealing device, of course, but I think it's necessary to have something really precise. So if you use the vessel sealer for the robot, this is a pretty huge device. Now they have a new device, the SynchroSeal, which is better, but still, I think not as thin as it should be for vessel dissection. But yeah.
Thank you.
Okay, let's go on.
Mhm.
The second step, again, the V look. So identification of the Iliocolic vessels and the window between the Iliocolic vessels and the mesenteric axis, there where the red point is. Okay, one more. This is the video. So the intestine goes on the left side, the small intestine, and then you see, then you identify the mesenteric window and divide it. And now I'm going much closer on this patient to the mesenteric artery, mesenteric axis, as you will see now. The Iliocolic vessels you see above there, this is, I point now on the window. Stop it here. Oh, it's okay. And you see, because I mobilized the mesenterium first, the window is easier to identify as there's some hematoma there. And now I identify the mesenteric axis. Okay, go on. So there's a vein. And because now I'm really much lower than in the video before, I have to be careful because the artery here is on the right side of the patient, yes, and the vein is on the left side. So be careful when you are really much lower than the insertion point of the Iliocolic vessels, because the vessels are switching sides.
Christian, I just want to say that only one person from our team performed robotic surgery, Artem Gacharov. He was asking something for you. Okay.
Yes, I have questions. Do you use? Do you have the experience with XI or with the SI? Because in Russia we have a lot of SI robots, but only 2 XI. And do you, if you want to do CME on the SI, do you perform in the same type of docking, or you use another one?
I have experience, or I started with the SI, but not with CME, just TME. And as we now don't have our SI system anymore, I've never tried it. And actually, I'm not sure if you can do such a narrow docking with the SI. I think there's the other technique is to have a line that is more to the left side. So and it's a similar, it's a half moon shaped line.
Yes. Yes.
But I'm not sure. I cannot tell you actually. I've never done it with the SI.
Okay. We use like a crossover type with the third hand in a position of first and second hand.
Okay.
The third hand from the right flank and helps to hold pedicle or transverse colon.
Okay.
But I think the next size is much more maybe comfortable or easier to perform CME.
Definitely. I know the difference from TME. It's much easier to do the docking and all the handling. So, yeah. Let's
Okay,
move on.
colleagues, let's move on. Mikhail?
Yeah. So now, one more time. So now we have our window, and now we have to identify the insertion of the vein and the artery, Iliocolic artery and the Iliocolic vein. And now I go on the vein first. It's easier to do the dissection there. And as we are still not so close to the insertion point, the artery is still on the right side of the patient, but will now switch to the left side. And what I do usually is I pull with 2 arms left and right and do the dissection. And okay, stop it here. So now you see already a little bit the insertion of the Iliocolic vein in the middle almost, and the SMA is still right, but it will move left. Okay, go on. And here I think it's the safest to go on the ventral side of the vein. And then on the right side. And then mobilize the insertion. Again, clips. Okay. You see here the artery is much more naked as before. And it's clearly identified and also clearly the Iliocolic artery is identified. So this is our step 4.
So Christian, you're routinely performing D3 dissection, yeah?
Not usually. It was more like to demonstrate that it's really practical with a robot. Okay, one more time. One more time. Yeah, so this is a slide showing the difference between D3 and D2 dissections. Well, yes, we can go on. It's from a Japanese paper. Okay, now is our step 5. We go upwards, go into the greater sac. One more time, yes. So we pull the transverse colon down. Then we incise the omentum below the gastroepiploic arcade. There we identify the back wall of the stomach. Then we open the bursa. Okay, the next step. Okay, one more time. And then again, we go to the right side of the patient where the gallbladder is situated. You see it back there. And hold the gastroepiploic arcade to the right side here, left side patient, and pull the omentum to the right side of the patient. And here again, we will then identify our already mobilized level of the pancreatic head there. So now we have the connection, and now it's much easier to identify everything, as you can have a look from below, from the side, and from above. Okay, one more time. And now we do the preparation of the right middle colic branch. Yes, one more time. When you see the colic vessels from the bursa, then I start the preparation from here and make a window into the mesocolon, and then you can switch from one side, from above or from dorsally. Have a look. Then you have to identify the right branch. And in this patient, so this is the artery, right branch of the middle colic artery. Okay, one more time. And in this patient, there was not a right colic vein from the middle colic vein, but bigger superior right colic vein draining into the trunk of Händle. So I switch from dorsally, I think. Well, let's go on. Let's have a look.
Mikhail?
Can you go on? Oh. I think it. Can you go one more? Can you go back once? It skipped once. No. Okay. Somehow it skipped the step, but there was just the right superior right colic vein draining into the trunk of Händle that was cut, and then the lateral mobilization I skipped in this video. And in robotic surgery, we perform an intracorporal anastomosis. Okay, go on. Side to side. So we stapled the ilium and the transverse colon. We do some stitches to hold it in place before that, and now I open the colon and then the ilium, and we do stapled anastomosis and suture the insertion point of the stapler later on. So here we didn't use the robotic stapler, just a normal stapler. You can also use the robotic stapler, doesn't matter. And then we suture. Or we close.
Christian, what type of anastomosis do you use in open or lap surgery? Stapled, hand sewn?
Depends a little bit. Usually I do an extracorporal anastomosis, end-to-end, two-layered. But if I do an extended resection, so extended right, then I will perform a intracorporal anastomosis, because usually I retrieve the specimen from the umbilical port, and when you do an extended resection, you are not able to pull it out as much as with a normal resection, in my view. So there I would use intracorporal anastomosis. Otherwise, I do extracorporal. But in robotic, I do always intracorporal. Okay, that's it.
Okay.
Well, thank you.
Thank you, Grayson. Thank you, Grayson, for next excellent presentation about robotic right hemicolectomy. Maybe someone, I actually think that only a few persons perform robotic surgery. Maybe Artyom can ask some question if you have, or if we have some questions in chat about robotic surgery. Artyom?
We have questions from Anton Tur. Thanks a lot for wonderful cases. One of the traditional robotic dilemma: on which post-operative day does red spot on a robotic surgeon's forehead disappear?
That's what this.
The red spot on the forehead on the surgeon.
That's good. I don't know. I've never looked in the mirror after robotic surgery. I don't know.
I have a question about transverse colon surgery. Do you think that robotic is a good option for transverse colon? Because sometimes you need to do much more extended resection and do iliosigmoid or iliodescendant anastomosis. Is it simple, maybe simple to with the lap for transverse, middle transverse?
I think it at least helps to perform the operation and makes it more easy to do it. I think you can also do it laparoscopically, so there is no disadvantage. And if you do really extended surgery, like if you do colectomy, I think it's getting a little bit harder with a robot, because you have to have multi-field views, and there you can maybe have to redock, so it makes it more complex, and maybe there it's easier to just do it laparoscopically. But of course I love the robot, and if I can, and if the robot is free, I would do it with the robot, but it's not always free, so I have to do it laparoscopically often too.
The same, the same story.
Yeah.
Victor Novikovs asked several times about how much length of ileum do you usually resect from the second? 5, 10, 1 centimeter?
Depends where the tumor is located. So if you really have a cecal tumor, I take more like in the last video with the robot. And if it's more in the ascendance, then I take less. But it also depends a little bit where you actually find your where you enter the window between the Iliocolic vessels and the mesenteric axis. So depends. So there's not a rule to that. Always put it at 5 centimeters. You have to be sure where you are with the vessels so that you can perform a good lymph dissection. So all the Iliocolic lymph nodes are at the specimen. And then when this is safe, then you have a look where you dissect the ileum. And so it's different from patient to patient.
And the next question is about the dissecting of the superior mesenteric artery or vein. Don't we need to go to the iliac artery on the right side of the vein or artery, not left side, or some iliac arteries on the left side on superior mesenteric artery? Do we need to dissect circumferentially the superior mesenteric artery?
Not standardized. So the lymph nodes there are actually ilial lymph nodes, and you don't have to take them as I did in the last video. So you don't have to do this actually. But of course, you have to differentiate it when you are close to the insertion points of the Iliocolic vessels. Of course, there you should take you should be at the mesenteric axis, so at the AMS or SMA and SMV, or the continuing of the SMA and SMV. So you make sure that you have the lymph nodes, the central lymph nodes of the Iliocolic vessels that are located at the lower angle to the mesenteric axis. Yeah.
So thank you.
Okay, Christian, thank you again for excellent presentations and great videos. You know, we have a very popular anecdote in countries. An elderly man dying and asked his grandfather to smell fish from kitchen, and asked to his grandson to bring him a small piece from kitchen. To this, his wife replied that this fish was cooked for later. So I have proposed to you to make our second part from total mesorectal excision next time. And we will have some benefits. We will see you again and your team. And our friends will also be here. Yeah. So is it okay?
Yes, for sure. I think
Okay.
will fit more. Yeah.
Yeah, yeah. Because our webinar is already 2 hours. Yeah, it's and I think it's a good proposal.
Yeah. So we can have a topic on TME.
Yeah, and we prepare also some videos. I know that Artyom can prepare about robotic total mesothelial excision, and Ilya will prepare about laparoscopic, and you will show, and we will have a nice conversation.
Okay.
So, ну что, друзья, Илья.
So was nice
Можно
to
и на
be
русском.
with you.
Илья,
Sound.
it's internet
Илья,
connection
тебя не
is
слышу.
good or not? Your microphone is out.
Я скажу пару слов на русском языке, потому что у вас в Германии, Кристиан, у вас в Германии наш друг, который соскучился по русскоязычной речи, и я специально для него это говорю, для Левши Сахарова, что и для всех остальных русскоязычных наших слушателей, что мне кажется, что был прекрасный вебинар, мы посмотрели совершенно другой взгляд, на мой взгляд, ну, как мне кажется, другой взгляд на выполнение этих вмешательств. Мы выполняем их немножко по-другому, у нас немножко другая школа, и мне кажется, всегда полезно посмотреть под другим углом на те вещи, которые мы делаем ежедневно. И я еще раз хочу напомнить, что спонсор нашего мероприятия сегодняшнего была компания Erba, абсолютно замечательная компания в отношении хирургии высоких энергий, моно- и биполярная коагуляция, которая, кстати говоря, в роботе да Винчи активно используется, как мы знаем. И говорим им спасибо за то, что они спонсировали сегодняшнее мероприятие. И я очень благодарен всей команде клиники в городе Erlangen, лично Кристину, лично профессорам, которые сегодня выступали. Пусть они передают привет профессору Хоенбергеру, который во многом изменил наше отношение к хирургии рака ободочной кишки. И до новых встреч, друзья. Я передаю слово нашим англоязычным коллегам и немецкоязычным коллегам. Всем счастья. Шоу, привет.
Christian, I will translate. Ilya said that he's very thankful for you, for your command, and we are very glad to see you because we all know about Professor Hohenberger, Professor Weber, and they show us good and very nice open technique, and now you show us very interesting technique in robotic and lap colon surgery. Thank you very much. Thank you for your time, and see you in our webinar online, or maybe a few months later and offline in Moscow. Or maybe we can come to Germany. Thank you.
Yeah, thank you.
Artyom.
It was a pleasure for us. Really nice webinar you established. I really like it. It's cool.
Thank you.
Yeah. Christian, finally, again, great thanks to you and your chief, Professor Guzman, and all your team that you have a time today with us to just give your experience, and huge regards to Professor Hohenberger. See you next time.
Okay.
Cheers.
See you.
See you later. Take care. Thank you.